All right, welcome to the final P&T meeting of 2024, December P&T meeting. This meeting is being recorded and will be posted to the OHA's website within a couple of weeks. We do have a quorum. Actually, we have significantly more. We have 8 committee members. So on the screen, you can see the general announcements. For those in the audience, if you're able to, or if you need assistance, please let us know, but we'd like to have your full name and your affiliation. So if you're with industry or one of the CCOs, if you could reflect that so that when we capture that information, it can be accurately reflected in the minutes. So with that, we still have a fairly robust agenda. So we're going to get started with roll calls and introductions. We've got the committee members on the screen in front of you. If you're following along in the audience, where the link to this material was, we have posted the agenda, all the packet of materials, as well as written testimony that was submitted for consideration. And if you're following along, I'll try to draw your attention to which page we are in the packet. So page 3 at this point for the roster. Doug, we'll let you lead off with introductions.
Douglas Carr, internist, medical director at Umpqua Health.
Welcome, Doug. Russ?
Hey, Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health.
Thanks, Russ. Dr. Anishi isn't able to join us, so Eddie, we'll turn it to you.
Hi, Eddie Saito, clinical pharmacist with Virginia Garcia Memorial Health Center and faculty with Pacific University School of Pharmacy.
Welcome, Eddie. And Pat also was not able to join us, got called to the clinic. So Kat, we'll turn to you.
Kat Livingston, medical director of health care and family physician at OHSU.
Welcome. Stacy?
Hey everyone, Stacy Ramirez. I am a primary care pharmacist and the director of pharmacy for the community health centers of Benton and Lynn counties and faculty at OSU College of Pharmacy. I also can now share that I'm going to be transitioning into a new role. So next month I will introduce myself differently and I'll just leave it at that.
Suspenseful. Thank you, Stacy. Tim also was called away for duties end of the year, I think inventory, so he won't be joining us. Bridget, we'll turn it over to you.
Yeah, my name is Bridget Bradley, and I'm a psychiatric pharmacist with Kaiser Northwest.
Welcome, Bridget. Samara?
Yep. Hi, I'm Samara Stevens. I am a natural physician in private practice in North Portland.
Welcome, and thanks for joining us. And Jeannie?
Good morning, Jeannie Savage, she and her pronouns. I'm the chief medical officer at Trillium and a family medicine OB provider at Salud Medical Center in Woodburn.
Welcome. Thank you all for being here and volunteering for this important information. Next, we'll turn it over to staff. Jennifer? I don't know if you're able to unmute yourself. All right, well, I'll lead the way then. Roger Citron, I'm the director of the Drug Use Research and Management Program, he, him pronouns. And again, we, the DERM, provide the clinical support to the Oregon Health Authority.
Hi, everybody. Thank you for your time today. This is Trevor Douglas. I am the director of Pharmacy Policy and Programs at the Oregon Health Authority.
Hello, I'm Dave Engen, a clinical pharmacist with the OSU DERM team.
Hi, I'm Sarah Fletcher. I'm one of the P&T co-coordinators for the OSU DERM team.
I'm Andrew Gibler. I'm the clinical pharmacy manager at Oregon Health Authority and also have a small faculty appointment with the DERM group.
Hi there, I'm Kyle Hamilton. I'm the pharmacy drug coordinator here at the OHA and the fee-for-service side.
Dan and Megan aren't joining us, so Deanna will turn to you.
Good afternoon. I'm Deanna Moretz. I'm one of the clinical pharmacists with the DERM team.
And I'm Kathy Centena, and I'm also a clinical pharmacist with the DERM team.
Hi, my name is Sarah Servid. I am the P&T clinical coordinator with the DERM group.
I'm Lynn Starkweather. I'm the pharmacy manager with Gainwell Technologies.
Dee Weston, she, her pronouns, pharmacy program policy advisor with OHA.
I don't know if I saw Brandon join, and Ted won't be joining us. So Brandon or Jennifer, are you able to unmute? All right. Well, Jennifer's the executive assistant, helps keep us on track, and Brandon is the pharmacy program analyst, so instrumental in our taking the information from this committee and implementing it with the Gainwell Technologies. So with that, we'll talk about conflict of interest declaration. As anybody that's signed up to provide public comment knows, we require conflict of interest declarations. Additionally, all of the P&T committee members and the staff that are supporting this important work have up-to-date conflict of interest declarations on file with the Oregon Health Authority. We do make sure that those are kept up to date, and we provide this opportunity if any of the committee members have a conflict of interest they need to declare that wasn't previously disclosed, or if they have any subjects they wish to or feel that they needed to recuse themselves from, we appreciate them doing so. But at this time, we'll see if the committee has any conflict of interest declarations. Hearing none, we'll turn to the approval of the agenda in the minutes. If you're following along in the packet of materials, the agenda starts on page 4. We'll ask the committee, see if they have any edits to those minutes, and if not, we would entertain a motion to approve them.
Motion to approve.
Thank you, Russ.
Second.
Appreciate it, Eddie.
All those in favor?
Aye.
Aye.
Anyone, oh, sorry. Anyone opposed? Abstain? All right, thank you.
And since it's very distracting, I am going to go off camera now, but I'm going to turn it over to Andrew to provide the department update.
Thanks, Roger. As many of you know, the legislation session will begin here in January, and it'll continue through most of June. And Dee Weston, who's on, as you all know, she'll provide regular legislative updates at each committee meeting, both during and after the long session. And I'll provide a nice brief and concise summary of any bills that may relate to Oregon's Medicaid program. And just a reminder that OHA and OHA staff don't take any position on any bill that goes through the legislature. So if any member of the public or anyone on the committee wishes to engage on a legislative item, we would be happy to connect you with the appropriate person at OHA. And as some of you are probably also aware, we want to let you know we are also aware that CMS issued a proposed rule to change Medicaid drug coverage requirements by requiring states to cover anti-obesity medications when used for weight loss in individuals with obesity. And so we're going to continue to monitor this proposal as it works through the system and update the committee on any permanent changes made. The Mental Health Clinical Advisory Group, which advises this committee, is almost done work and almost ready to publish their treatment guidance for post-traumatic stress disorder. So I will bring that back to you hopefully at the next committee meeting, summarizing their recommendations for PTSD. And we'll also would like to invite you to let me know if you have any ideas or priorities that you would like the Mental Health Clinical Advisory Group to focus on in 2025. We have one idea to get started, but we would encourage the committee and any member on the committee to reach out to me or Roger or Trevor or anyone if you have an idea on treatment guidance for a particular mental health condition that you think would be important for the work of this committee. So with that, I'm going to hand it off to Dee Weston, and she's going to talk about the EPSDT program.
All right, thank you, Andrew. I'm about to click send. So in the chat, you'll see a link to a program page that corresponds to what I'm going to briefly talk about. I was asked to describe YSHN, that is the Young Adults with Special Health Care Needs change that's coming up. Starting January 1st, 2025, OHP will apply early and periodic screening, diagnostic, and treatment, otherwise known as EPSDT, benefits to older OHP members in select groups. That to qualify, the person must be 19 or 20 years old in 2025 and must have at least one qualifying healthcare need that began before the age of 19. And there are also income eligibility. So for our purposes, normally we would think that EPSDT, the kinds of concerns that we think about of ensuring that there's access to coverage of medically necessary and appropriate services to people under the age of 21, that age will increase slightly. So if they meet the criteria, they were 19 or 20 in 2025, and their condition began before age 19, then that consideration of ensuring coverage to necessary and appropriate services would continue past the age of once they're 21 and beyond. It's a little confusing. The bottom line is age 21 we'll be looking at for eligibility under this program in next year. It won't just automatically cut off. Like I said, it's a little confusing. That's why I put the link to the program page. Please look there to find more information. We hope to extend this program further into the future, not just next year. That is subject to funding. That's all I have.
Thank you, Dee. Any questions for Dee? Okay.
I had a very general question that I'm not sure. It may be a topic for another discussion, but I'm curious if how much planning is being put into the end of the prioritized list, and how that may, because I know in the past some of our decisions have been based on the fact that things are, typically above or below the line, and so I'm not sure how if how much work is going to be involved in what changing any of that for us, but I'm curious, if what's being done.
Roger,
That is a great question,
Yes.
Russ. And so, yeah, that is the prioritized list. January of 27 will be going away. We no longer have that waiver with CMS. And at that point, we'll no longer have criteria that will be saying, is the condition funded? No, deny claims. But currently, what we've done through the implementation and adoption of EPSDT criteria are having questions that at the point where we've asked, is it unfunded? We've said, yeah, but is the member less than 21? And we then have a pathway that we consider medical appropriateness and medical necessity. So that's really paving the way in those criteria. We've been asking that question to actually still have a pathway by which we can cover needed medications. So that's one of the things we'll be doing, is having a transition through the EPSDT. Now this expansion, as Dee just described, through WISHN. And then as we approach that, that those questions will lend itself towards that medical necessity and appropriateness. Complementing that, as you recall, like through the year, we have in some cases added coverage and opened up access for example, topical moisturizers. So things that might be used for or prescribed for unfunded conditions currently, but they're cost-effective treatments. We've been intentionally trying to open up access for those. And one of the things we'll be considering is in certain conditions, like maybe mild skin conditions, explicitly bringing back to the committee dedicated step therapy, where we can ask, have they used or tried, particularly these modalities that we're trying to make available without restriction. So it's kind of a multi-pronged approach, but some of the work that we're doing, a lot of the work that we're doing with under EPSDT, will really set the stage for the removal of the prioritized list question and making sure that coverage is appropriate and necessary. Does that help, Russ?
Yeah, thank you.
You bet. Good question. Appreciate that. All right. So again, as a reminder, the P&T committee. Yeah, Kat.
Oh, I just had a follow-up on that. That was a super helpful description. One of the things that's come up in discussion on the physical health and HERC QHOC side has been about creating a really nice synthesis of the new conditions that will be covered, or new conditions and or treatments that will be covered as a result of removal of the prioritized list. And I wonder if the plan is to also do that in the pharmacy space. It sounded like the timeline for producing that on the HERC side was in December of next year. I'm wondering if the plan is to also have that on the pharmacy side, to have a pretty clear summary of new expected coverage of drugs that then would be helpful from a clinical perspective, and then also obviously inform the rates discussion as well.
Yeah, the rates discussion is kind of outside of us. We try to help that as if we're asked, but I know they have lots of different outreach for that. We meet with the folks with HERC regularly, and so appreciate that update. And as far as what they're doing, we're trying to complement their actions at this point. So I appreciate the request or suggestion that we consider something similarly. Again, we don't generally require diagnoses for drugs that are being prescribed through the point of sale, only when we stop medication because we know it might be currently prescribed for an unfunded condition, or we want to have utilization controls for safety or efficacy or cost effectiveness compared to other drugs in the class, then we'll ask that question. So I don't know if our list would be as comprehensive, but in those conditions that are currently unfunded, we'll take away the suggestion to consider some kind of coverage guidance or a roadmap to where we're planning to go with maybe opening up coverage for certain drugs that maybe for example the TIMS or things that might be having that bridging the space between currently funded high prioritized moderate to severe conditions to the mild, and help kind of with a roadmap going forward. So nothing explicit this, but we do coordinate with HERC all the time, so we'll take that as a takeaway to consider what might be useful.
Thank you.
Roger, this is Andrew. This committee will be the ones that are approving those changes as we go through the process, correct?
For the coverage of drugs, right? HERC
Right.
is quick to tell you that they don't do drugs. They don't make coverage policy for explicit drugs. They do, and they will continue to have guideline notes. And so recommendations, some of the work they did, for example, for, opioids for low back pain, those will continue to be part of the prioritized list and very useful for us for coverage guidance. But as we look for maybe classes that currently weren't covered, constipation, that space, we'll look at maybe having kind of a roadmap for what we're doing going forward. Any other questions? All right. Well, as a reminder, the P&T committee also serves as the federally mandated DUR board. So we try to focus, we do focus one meeting each quarter on DUR activities. And since there are 2 meetings a year in the fourth quarter, October and December, we always do it in the second meeting. So part of that is some of our DUR. One of the things we produce is a quarterly utilization report. You've seen it many times. It's posted on our website. So that's part of the consent agenda. We will get into DUR activities shortly. But if you're following along in the packet of materials, the consent agenda starts with the quarterly utilization report on page 9. We also have a literature scan. Those, when they're part of the consent agenda, generally are no changes are recommended based on the evidence. We're just setting this up so that we can go look at the class in executive session. And our oncology PA policy just lets us add new agents to make sure that they're being supported by their FDA-approved indication or NCCN guidelines. So if the committee has any questions, we can take a topic off of the consent agenda, but if not, we would entertain a motion to approve the recommendations.
This is Jeannie. I'll make a recommendation.
Thank you, Jeannie.
Doug Carr, second.
Thank you, Doug.
All right, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you, everyone.
So as I mentioned, DUR activities, those are led off with ProDUR or prospective DUR that happens at the point of sale. Lan Starkweather is here. She's represents is the pharmacy director for the Gainwell Technologies, the pharmacy benefit administrator for the OHA. So I'm going to turn it over to Lan and direct the audience, if you're following along on the packet, to page 41.
Thank you, Roger.
Oh, 47, sorry.
This is a high-level summary of the DUR activity for the quarter. On the left-hand side, you can see all the different types of alert. I provided an example of what the kind of things that might trigger those alerts, and then the disposition for the claim. And so for the entire third quarter of 24, we had 165,000 alerts registered in the system. A majority of the alerts are set to just informational or for the pharmacist to be aware of. Only 2 are set to deny the claim and actually need a pharmacist intervention in order to bypass. That's the early refill alert and also the pregnancy drug interaction alert. Those are highlighted in yellow. So for the early refill, we had 105,000 alerts for the quarter. Approximately 23.5% of those were overridden. And then for pregnancy, 40 alerts were registered, 22 of those were overridden. Next page. And here are the top drugs that are enforced in the DUR alerts. These are primarily the fee-for-service carve-out drugs, so the mental health. Majority of them is the serotonin reuptake inhibitors, so sertraline, fluoxetine, escitalopram, and citalopram. That's in the first table. Followed by the next table is just the other antidepressants, and those primarily bupropion had the highest alert for that category. And then other alerts that registered were the antipsychotics. These are primarily the second generation antipsychotics. Seroquel is the one with the most alerts. And then other mental health carve-outs are the lamotrigine, Depakote. Those have quite a bit of alerts too, but again, these are primarily the mental health carve-outs for fee-for-service. This page just shows the early refill reasons. So this will, the pharmacist will enter in why they need to have an early refill. A majority of the early refill alerts is due to submission clarifications of 7, which is medically necessary. The other 12% is due to a change in therapy. And then lastly is the cost saving report from the prospective DUR. For July, we had 75 claims that did not get dispensed, so that's a 19,000 cost savings. August 265, so this is corresponding to the summer months when people are trying to travel, but 265 claims that did not fill, so $84,000 in cost saving. And then we had 6 prescriptions for September, cost savings of $927. So overall for the quarter, $105,000 in cost savings. Any questions on the prospective DUR?
Great, thank you, Lan. The next phase of DUR would be retrospective. We take care of that with an analysis of the claims. We have a report starting on page 51 in the packet, and we'll turn it over to Dave.
All right, thank you, Roger. Yeah, so for the latest RetroDUR report, we're looking at Q4 data. So that's July through September of 2024. And as usual, I'll just hit the high points of this report. On this page, you'll see the initiative billing correction review. That's where we keep track of our high dollar claims that may have been billed incorrectly for patients that might have other coverage. There's a lot of moving parts in this report, and things are still being fleshed out. So as we compile more data and figure out kind of the optimal workflow, we hope to report some successes and financial numbers at future meetings. Go to page 52, you see our change forms. We're still seeing opportunities for providers to change more cost-effective formulation. We're hoping to add some more as they come up and as we find new opportunities. The savings from the aripiprazole and vaccine switches, they continue to accumulate over time. You can look back quarter over quarter and see that. We'll likely turn off the venlafaxine initiative before the next meeting, but really we can leave it running in the background for now, and it doesn't hurt anything. So we'll look for more opportunities, and once again, if you hear of others, always happy to entertain those ideas. So page 53. This captures our messaging to prescribers about dose consolidation. Yeah, and we didn't need to send out any letters in Q4, likely because the messaging is going on at point of sale at the pharmacies. So we'll see the next quarter if that happens, if more come up. But page 54, that's our expert consultation referral for long-term antipsychotic use in kids. There's lots of patients that are screened, a handful that are flagged as high risk. Here, about half a dozen or so prescribers receive a referral to Opal K for a consult. And that's noted in those numbers there. Yeah, if we go to page 55, this is our messaging to prescribers about patient non-adherence to their antipsychotics. And we're still getting some traction on that, and seeing almost half the patients refill their medication in the next 90 days after their prescriber was notified. So we'll definitely keep that one going. On page 56, this lists the different individualized profile reviews for children in foster care, and as well as for patients with a variety of high-risk conditions. You can see there bipolar, polypharmacy, chronic opioids, and those types of things. So yeah, the review totals and the lettering needs are staying fairly consistent quarter by quarter, so you can look over those and see that. Yeah, page 57. That's our safety net program. It's for antipsychotics in really young children. For this initiative, if we know a PA is ending, then we proactively notify the prescribers to submit a new PA for their patient, and then inform them of the main requirements so patients get appropriate care with no interruption in therapy. The numbers are pretty consistent there for each quarter. And if you look on page 58, that's where we report our safety net monitoring. The first one's for patients on dangerous opioid sedative combos. And overall, the numbers, they're lower since Q3, and still roughly about half of those prescription combos are being discontinued within 3 months after notification. Also, you can see there's a handful of prescribers that are being notified if their patient's been denied an oncology med with no evidence of a fill for an alternative agent. And then we do the same thing for prescribers whose pediatric patients were denied a TCA, but then there was no alternative filled or requested. And in Q4, you can just see that there's fewer denials, so fewer notifications went out. So all good things. Yeah, basically that is a summary of our RetroDur report. And as I've stated before, if you think of or hear of new opportunities in this space, let us know and we can investigate new ideas. But if there's no other questions, I'll turn it back over to Roger.
There was a question, Kat, you posed in the chat asking for the antipsychotic measure if, as long as the gap is less than 90 days, would they then be okay? Would they not be subject to this? And I defer to the team to correct me if I'm wrong, but that is correct. If it doesn't hit that threshold of the 90 days, then it wouldn't be triggered for that outreach.
Okay, so that means for any of these, whether it's the 60 days for the little kids or 90 days, if they are not taking medicines for up to the 59 or 89 days, then they're considered adherent. Is that true? Ish.
I don't know if we'd consider them adherent, but they're not subject to our trying to do outreach to engage at that point. It's
Got it.
once we're,
Okay.
yeah.
And
Any other questions? Go
sorry,
ahead.
just geeking out for a moment on this because
Please, yeah, we appreciate that.
and so I understand like this the intervention here is about whether to do outreach or not, but curious about how this aligns with the HEDIS measure on antipsychotic adherence. Is it related to that, or is this an independent intervention that we've identified?
It's independent. It's just making the intent with this policy that's on the screen right now is to make sure when kids look like they're starting on what's long-term therapy, and these are kids in this intervention that are less than 10 years old, that therapy is appropriate, is the intent of this policy. And so we're reaching out to Opal to get in contact with the prescriber for that consultation.
Yeah, thanks. Sorry, I was talking about the earlier ones as well, and not specific to the one that's on the screen right now.
I think all of these don't necessarily correlate with the HEDIS measures.
Right. Some have come up through various acts, but not necessarily guided by HEDIS measures.
Okay, makes sense. Thanks.
Thank you.
Appreciate it. Good question, Kat. And you can geek out on us with us anytime you want. All right. So next up, we're going to turn it over to Kathy Centena. We have our newsletters, which is one of the ways that we do education, which is also a DUR requirement federally. And page 59 starts the first newsletter for one of our recent ones. Kathy, I'll turn it to you.
Great, thanks, Roger. So yeah, today we're actually recapping 3 of the newsletters. As Roger mentioned, we have our first one that was published in April, and that was on medication holidays. This newsletter discusses the potential benefits of medication holidays for just a few therapeutic drug classes. The second newsletter was published in May, and that's on safety risks with long-term use of proton pump inhibitors. So the newsletter kind of summarizes these safety issues related to long-term use, as well as it discusses deprescribing options for PPIs for those patients that are eligible. And then the third newsletter was on critical access pharmacies that was published in June. And this goes over the crucial role of these pharmacies, as well as to preserve pharmacy access for vulnerable communities. Again, thanks so much to the authors that write these newsletters, and for the committee for providing feedback as well as suggestions. And just as Dave mentioned, for RetroDur, we are always open to any topic suggestions for newsletter ideas and provider education. So I don't know if anyone has those now. We'd love to hear them, or you can always email us as well. So yeah, so email us at any time if you have an idea, and then you can sign up on our website to receive the newsletters electronically. And I also encourage you to take a look at our recently posted newsletter on biosimilars.
Thank you, Kathy. All right. Well, we're going to start in with some of our new business. We have our orphan drug and biologic rare disease PA update. Generally, this is part of our consent agenda, but we're making a little bit more broad changes. So I'm going to turn it over to Sarah Fletcher and direct your attention to page 71 if you're following along in the packet.
Roger, as you said, this is just a prioritization update related to the biologics for rare conditions in the orphan drug class. And the purpose is to look at the utilization for the biologics for rare conditions class, and then to do our normal addition of medications to the orphan drug policy. Go to the next slide. The biologics for rare conditions class includes medicines that are not for common conditions. So things like paroxysmal nocturnal hemoglobinuria or neuromyelitis optica spectrum disorder. And since we started the class in 2021, it's been updated 4 times because of new approvals and expanded indications. And it's already due another update because of 1 new agent, 2 new biosimilars, and some new indications. And all of these medications that are currently in the class are an orphan drug. So they're designed to treat fewer than 200 patients, or fewer than 200,000 people in the US have the condition, or if it's more, they're not expected to recoup their costs for developing the drug. You go to the next slide. Despite all of the updates that we've done, there are only 2 patients in the 2-year period from mid-July of 2022 until June of 2024 who've gotten more than 1 dose of a medicine from this class. And I went through and compared the existing drug-specific PAs to our orphan drug policy. And our orphan drug policy basically holds medications to their labeled indication and includes requirements for any monitoring that is specifically in the prior authorization or in the package insert. And all of them pretty much align with the exception of Vyvgart, which has step therapy for its myasthenia gravis based off its drug-specific PA. And then our normal orphan drug update, there are 2 new agents for Niemann-Pick that we wanted to add to the orphan drug policy. If we go to the next slide, this is just really quick. These are the recommendations that I wanted to move every drug in that class except Vyvgart over to the orphan drug policy. So Uplinza, Ultomiris, Inspring, Solaris, Bechem, Ebsquali, Empavali, and Piaski, and then to remove the existing PDL status on the ones that have a PDL status and to retire all of these drug-specific PAs. And the reason for this is just for improvement of efficiency because we're not having a lot of use, but we're spending a lot of time looking at these updates. And then the other recommendations to add those 2 drugs for Niemann-Pick disease to the orphan drug policy. The 1 drug that's not moving is Vyvgart again. So that's all I had. Any questions?
Thank you, Sarah. Any questions about the recommendation? Okay. So again, the recommendation of the committee is to move those designated agents to the orphan drug policy, remove their PDL status and retire their dedicated PA criteria. And then also to add, I can't even pronounce it.
I didn't even try.
Right?
For Niemann-Pick.
Add the 2 new agents to the orphan drug policy. Do we have a motion to approve?
So moved.
Thank you, Kat.
Second. Doug Carr.
Thank you, Doug.
All right, all those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you.
Great. All right, cruising right along. Draw your attention to page 94 if you're following on the packet of materials. And we have the targeted therapy for Alzheimer's class update. And we've got a new drug evaluation. So Dave, the floor is yours.
All right, thank you. Yeah, so today we'll review the Alzheimer's disease drug class. And we'll briefly examine the new literature since the last time the class was covered, and we'll also look at the safety and efficacy of the new drug donanemab. So previous reviews found that acetylcholinesterase inhibitors have modest benefit in improving outcomes such as cognition and activities of daily living in patients with AD. But there's insufficient comparative evidence to suggest any one agent is clearly better than another. And no agent can stop or reverse the underlying process of disease progression in AD, or has demonstrated an impact on clinically meaningful outcomes such as mortality and disability. There's insufficient evidence that amyloid-reducing therapies for mild AD have an impact on clinically meaningful outcomes. However, it's well established that amyloid-reducing therapies have significant increased risk of amyloid-related imaging abnormalities, referred to as ARIA, compared to placebo. Which brings me to the latest. If we go to the next slide, The latest FDA safety alert since a previous review of this class showed that lecanemab, it now has a black box warning added for ARIA and serious life-threatening events. And the warning also emphasized that testing for ApoE4 status should be performed prior to initiation of treatment because that's the higher risk subpopulation of patients with AD. Lecanemab is also contraindicated in patients with serious hypersensitivity to the drug, hypersensitive reactions, including angioedema, bronchospasm, anaphylaxis. Those types have occurred. So prescribers are urged to promptly discontinue the infusion upon the first observation of any signs or symptoms consistent with the hypersensitivity reaction and to initiate appropriate therapy. All right, we want to go to the next. Another amyloid therapy, amyloid lowering therapy in the form of monoclonal antibody has been recently approved. It's called donanemab. Trade name is Kisunla. It's indicated for the treatment of AD in patients with mild cognitive impairment or mild dementia. The FDA used findings from mainly one randomized controlled trial called Trailblazer ALZ-2. And it was a phase 3 double-blind placebo-controlled study over 76 weeks. It included patients between 60 and 85 with mild AD or MCI due to AD with evidence of amyloid and tau pathology. The primary efficacy endpoint was change from baseline to 76 weeks in cognition and function as measured by the Integrated Alzheimer's Disease Rating Scale. And that particular scale has a score range of 0 to 144, where lower scores are indicative of greater disease severity. Treatment with donanemab resulted in less decline on the IADRS scale of about 3 points compared to placebo, which was statistically significant. If I could have you, Sarah, just skip to the clinical safety slide. I think it might be a couple ahead. Thank you. There were some noteworthy safety issues at the doses used in the trial, mostly ARIA and infusion reactions, which has also been highlighted as a black box warning. Overall, about 37% of the donanemab group experienced ARIA compared to about 15% in the placebo group, and a breakdown is shown in the table here. There were also infusion-related reactions more commonly found in the donanemab group. You can see 9% compared to placebo, which was under 1%. So if we go back now to the previous slide. So as far as the trial limitations, it's unclear if a 3-point difference on a 144-point IADRS scale has clinically meaningful effects in cognition and function in patients with AD. Since the minimal clinically meaningful change that was conveyed in the study was 5 points for those with MCI and 9 points for those with mild dementia and AD. So there was also a higher number of discontinuations in the donanemab group compared to placebo, and the FDA highlighted that only 7% of the subjects who discontinued treatment had follow-up and completed the study. And it's unknown whether or to what extent decreases in whole brain volume and or beta amyloid plaque levels have an impact on Alzheimer's disease progression or adverse effects. And there's insufficient evidence to verify long-term safety in older populations, those with comorbidities and or multiple drug therapies, and those who had experienced ARIA. We also don't know if donanemab has any benefit in moderate to advanced AD, or if it has sustained benefit if or when the drug is to be discontinued. So I'd like to take a few minutes to look at the updates to our PA criteria. We updated to include this agent and remove agents that are no longer available. You can see here the dosing schedule and MRI monitoring schedule for donanemab. Go to the next slide. Yeah, we removed the agent that is no longer available. Go ahead and if you want to skip, I think 2 slides is the next change that we see. Yeah, on this slide, we just simplified the concurrent anticoagulant or antiplatelet therapy question. And if we go to the next slide, here's where we included donanemab, and we included the requirement for amyloid plaque assessment. And the next slide, if amyloid plaque levels drop below predetermined threshold levels, the providers are encouraged to stop dosing, as was done in the study. And so essentially that is it for the review for donanemab. Go ahead on the next slide, please. And yeah, so the recommendations are to designate donanemab as non-preferred on the PDL, implement PA criteria for donanemab, and update existing criteria as proposed. So, didn't know if there were any questions. Otherwise, I think we have some public comment.
Any questions for Dave?
I have a question. So does this mean that this drug has no clinically important improvement in outcomes and it has known harms? And therefore we're covering it because we were required to by the FDA? I just want to make sure I'm tracking appropriately.
As far as predetermined what's considered clinically meaningful, that was identified in the trial even up front, it didn't meet that clinical threshold. I think you would have folks argue what clinically meaningful represents and how much is clinically meaningful. But in this case, as far as those strict definitions, it did not meet. It wasn't considered clinically meaningful based on how it was set up. It was statistically significant changes in these scales, of course, but clinical meaningfulness is debatable in that sense. So yeah, and in this case, we're not designating it as preferred, but yes, it would be added as non-preferred to the PDL drug list.
And hey, Dave, just a follow up to Kat's question.
Mhm.
But there does have to be a path, like we have to have some pathway to coverage, right? We can't just say we're not covering this.
Right, and
Okay.
Roger, you're welcome to speak more to this, but yeah, we do need to have a pathway to coverage. Although we have set up this criteria, especially due to the fact that there are known harms with this agent, as any drug agent has potential harms. We have criteria set up that kind of put safeguards in place.
Yep, that's correct. So FDA approved indications for manufacturers, medications, when they've signed the federal rebate agreement, we need that pathway to coverage. So, we can certainly have utilization controls for safety, and some of the best tools we have to bring to bear are if there's efficacy. If we approve it, it's the continuation to demonstrate that they're actually getting benefit. So that's what we're trying to thread the needle with.
Right, and I
Other
figured
questions? Yeah, go
I
ahead,
was gonna-
Stacey.
we could also debate all day clinically significant. I think that could be a whole meeting.
No
It
doubt.
certainly could.
Especially within this
Exactly.
particular category of medications. Yeah.
Yes. Thank you guys for clarifying. And thanks, Kat, for asking the question. You pretty much read my mind.
Other questions for Dave? All right, we do have 2 people that have signed up for public comment. I'm going to share my screen so we have a timer. Irene Liu or Lee from Eli Lilly, are you able to unmute your line?
Hi, thank you, Roger. Good afternoon. My name is Irene Louie. I'm a pharmacist and health outcomes liaison with Eli Lilly. Here's my testimony on donanemab, known under the brand name of Kisunla. You guys have heard that it's an amyloid beta-directed antibody indicated for the treatment of Alzheimer's disease. It's available in 350 milligram per 20 ml single-dose vials, and the recommended dosage is 700 milligrams administered as an IV infusion over approximately 30 minutes every 4 weeks for the first 3 doses, followed by 1,400 milligrams every 4 weeks. Providers should obtain a recent baseline brain MRI prior to initiating treatment and prior to the 2nd, 3rd, 4th, and 7th infusions. If radiographically observed ARIA occurs, treatment recommendations are based on type, severity, and presence of symptoms. There was discussion about efficacy of donanemab. It was established in Trailblazer, also you guys briefly reviewed. I will also add that patients in the low medium tau populations treated with donanemab did have a 39% lower risk of progressing to the next stage of disease as measured by the CDR Global score through week 76, and patients in the combined tau population treated with donanemab had a 37% lower risk of progressing to the next stage of disease as measured by the CDR Global score as well. The prescribing information for donanemab also includes warnings and precautions related to ARIA, infusion-related reactions and hypersensitivity. Monoclonal antibodies directed against aggregated forms of beta amyloid, including donanemab, do carry this box warning. And full safety details are available in the prescribing information. Thanks for the opportunity to address the board. I'd be happy to entertain any questions.
Appreciate the testimony. Any questions for Irene? Okay, thank you. Next, we have Craig Plauschenot from ESI. And are you able to unmute your line?
Yes, I can cede my time back. Thanks, Roger.
All right.
Thank you.
Thank you very much. I won't put you on the hot seat and ask if the committee has any questions for you then. So with that, if we can bring the recommendations back up. So the recommendations that Dave put from front of me is to designate donanemab as non-preferred on the PDL and to implement the PA criteria and the changes that he had outlined in the packet. So again, any discussion? And if not, we would entertain a motion to approve.
Approve the pathway to coverage with the criteria as outlined.
Thank you, Doug.
This is Jeannie. I second.
Appreciate it, Jeannie.
All right, all those in favor?
Aye.
Aye.
Aye. Anyone opposed? Abstain? All right, thank you all.
Fantastic. Next, we're going to go to the pulmonary hypertension class update. It starts on page 120 in your packet, and I'll turn it over to Sarah Servant.
Thank you. So today we're going to be talking about updated evidence in the pulmonary hypertension space and looking at evidence for a new drug that was recently approved by the FDA. Just as a little bit of background, pulmonary hypertension is kind of classified into 5 different categories based on the cause of the pulmonary hypertension. You can see the categories here. The most common ones are generally heart failure and COPD are the most common causes of pulmonary hypertension, and those fall into groups 2 and 3 as classified by the World Health Organization. Those particular causes of pulmonary hypertension don't have any direct targeted treatments. The most common categorization of pulmonary hypertension that has drug treatments is World Health Organization Group 1, pulmonary arterial hypertension. So that's where we're going to focus most of our time today. PAH is generally more common in females than males. And there are multiple types of drugs that are used to treat that particular type of pulmonary hypertension. There are a few drugs that are approved for other types of pulmonary hypertension. Riociguat is approved in group 4, and inhaled treprostinil is approved in certain types of group 3 pulmonary hypertension due to interstitial lung disease. Guidelines generally recommend combination treatment for everyone with pulmonary arterial hypertension or PAH, starting with tadalafil and ambrisentan if people have class 2 or 3 symptoms. Class 2 symptoms designate slight limitations in physical activity. So like ordinary physical activity generally causes symptoms of breathlessness, for example. Class 3 symptoms are slightly more severe, so less than ordinary activity causes symptoms, and then class 4 symptoms are when a person has those symptoms at rest. Guidelines generally recommend that if people are unable to do combination treatment, use monotherapy with one of the types of medications that's available, either erythrocyte receptor agonist, phosphodiesterase 5 inhibitor, or soluble guanylate cyclase inhibitor. And prostacyclines are recommended for people with more severe symptoms. This is our current policy. We do have a handful of preferred products. Sildenafil tablets, when they have indications for PAH, are currently preferred. Bosentan is preferred as it has evidence for decreased hospitalizations. And IV epoprostenol is preferred because it has also shown some mortality benefit in people with more severe symptoms. Non-preferred products include phosphodiesterase 5 inhibitors with indications for erectile dysfunction, because that is one of the other indications that that class of medications has. The OHA doesn't currently cover treatments for erectile dysfunction, but we do cover treatments for pulmonary arterial hypertension. And PA is required only for non-preferred products currently. Our PA criteria limits use to people who are prescribed therapy from a pulmonologist or a cardiologist, and they have to have class 2 through 4 symptoms. And then we do have pathways for the riociguat in people with group 4 pulmonary hypertension, consistent with the labeling, and then for the IV prostacyclines for people with class 3 through 4 symptoms, because those are generally reserved for people with more severe symptoms. And taking a look at the new evidence, this review didn't identify any new comparative, high-quality systematic reviews or guidelines. There were a few new FDA-approved formulations and indications since we last looked at this class. Sildenafil did receive an expanded indication for pediatric patients with PAH. This was based on a couple different randomized controlled trials. One was in 234 pediatric patients, and they were looking at measures of lung function using a maximum volume of oxygen consumed, so a non-clinical primary endpoint. That particular endpoint didn't meet statistical differences from placebo, but some of their secondary endpoints did show that people treated with sildenafil, particularly high-dose sildenafil, had improvement in World Health Organization functional classes. They also did a dose comparison study in adults, which demonstrated improved mortality in people prescribed higher doses of sildenafil, and that was used to partially support this approval for pediatric patients. Treprostinil dry powdered inhaler was also approved. This is a new formulation. It was previously available as an inhaled solution. And there's a combination tablet approved, the Macetin tadalafil combination tablet. These were both available previously as monotherapy. And a new RCT did demonstrate that the combination therapy demonstrated improved symptoms compared to either monotherapy alone. As far as new safety labeling changes, the labeling for inhaled treprostinil was updated to include risk for bronchospasm, particularly in patients who had COPD or other pre-existing lung conditions. A randomized control trial was published that compared inhaled treprostinil to placebo in people with moderate to severe pulmonary arterial hypertension and COPD. And that trial was discontinued early after an interim analysis found increased risk of serious adverse events associated with treatment. Differences between the two groups were about 25% of people in the treprostinil group with a serious adverse event compared to 10% of people in the placebo group. Serious adverse events included COPD exacerbations and acute respiratory failure. There were 6 deaths that occurred during the study, 5 of which were in people randomized to treatment. And so that is included in the labeling for the inhaled treprostinil as far as risk for bronchospasm in people with lung function and pre-existing lung diseases. Safety labeling was also updated for riociguat, just to mention that it's contraindicated with other medications that have the same mechanism of action. And then taking a look at the new drug, sotatercept, which was FDA approved primarily based on a single phase 3 double-blind placebo-controlled randomized controlled trial. There was supporting evidence from phase 2 studies that the FDA looked at as well. This phase 3 study included over 300 patients that had pulmonary arterial hypertension. They mostly enrolled female and white participants. And patients were on multiple other drugs for pulmonary arterial hypertension. About 61% of people were on 3 other treatments, 35% were on 2 other medications. People had enrolled in the study had functional class 2 or 3 symptoms and could walk for an average of 400 meters on the 6-minute walking distance test. They did exclude people who had severe lung function or untreated obstructive sleep apnea, had various types of heart disease, and then had laboratory abnormalities, particularly elevated hemoglobin or high blood pressure and low platelets, since those are adverse effects of the sotatercept. Their primary endpoint, improvement on the 6-minute walking distance, was evaluated at 24 weeks, and they did have a secondary endpoint looking at clinical worsening events that was evaluated. People could enroll in the trial for up to 72 weeks to evaluate that endpoint. The primary endpoint was improved with sotatercept compared to placebo. The median difference between treatment groups was about 41 meters. Secondary outcomes were also improved with sotatercept compared to placebo. More people in the sotatercept group had functional class improvement at about 30% of people compared to close to 14% in the placebo group. And sotatercept improved the time to the first clinical worsening event compared to placebo as well. At about a median of 33 weeks, 5% of people in the sotatercept group had a clinical worsening event compared to 26% of people in the placebo group. And this clinical worsening event is a composite endpoint that includes multiple different outcomes, and those are outlined in the packet if you're interested. As far as safety of sotatercept, some of the most common adverse events are outlined here, and those do include elevated hemoglobin levels, low platelet levels, nosebleeds or epistaxis, telangiectasias, and bacterial infections were all more common with the sotatercept compared to placebo. And so the labeling for sotatercept does include warnings and precautions for hematologic adverse events, serious bleeding, as well as embryo-fetal toxicity and impaired fertility. And then getting into some of the evidence limitations for this drug, there were some imbalances between groups in baseline PAH etiology, time-sense diagnosis, and comorbid conditions. It's not really clear how those might affect results, but it may increase risk of bias for differences between the groups. There was risk for unblinding due to adverse events during the trial, particularly with laboratory abnormalities and bleeding events. Evidence is most applicable to people with moderate symptoms of PAH who are on multiple other drugs. And in general, non-white races were underrepresented in the study. At this time, we have insufficient evidence in people with more severe symptoms or comorbid conditions such as heart disease, and the long-term efficacy and safety beyond 1 to 2 years remains unknown. And then shifting gears a little bit, we did look at the utilization in this class. We took a look at anyone within about a 2-year period who had claims for pulmonary arterial hypertension drugs. We did exclude people who likely had incomplete claims data, but looked at oral, inhaled, and injectable therapies through the pharmacy benefit. Our outcomes that we looked at, we were mostly trying to determine indication that these therapies were used for and determine if people were using concomitant therapy as recommended by guidelines. So we were looking at PAH diagnosis for these members in the 6 months before or 3 months after their first paid claim for a pulmonary hypertension drug, looking for other drugs within the 3 months following that claim, looking at provider type, and then dose on the claim as well, since doses for pulmonary hypertension are typically higher than doses for erectile dysfunction for the phosphodiesterase 5 inhibitors. And then here you can see our results. We did identify about 131 members with claims for a PAH drug in fee-for-service over the course of 2 years. We included about a little over half of those members in this analysis that we thought had complete claims data. By and large, therapies or claims were for phosphodiesterase 5 inhibitors, mostly preferred products which don't currently require PA. And the analysis that we did strongly suggests that most of these pharmacy claims for the oral phosphodiesterase 5 inhibitors are proudly prescribed for erectile dysfunction and aren't prescribed for pulmonary arterial hypertension. We found a diagnosis of PAH only for 16% of members. Most members were male, 90% male, and PAH is more prevalent in female participants or female patients. Only 4% of members had combination therapy with another type of PAH drug, and guidelines recommend combination treatment for everyone who has some class 2 or class 3 symptoms. Only 10% of people had a prescription from a cardiopulmonary provider, and generally most doses were for sildenafil were lower doses, less than 60 milligrams per day, which is not recommended for pulmonary arterial hypertension. The higher doses are generally recommended. And so the recommendations that I have for you today are to implement PA criteria for sotatercept, to support use as add-on treatment in pulmonary arterial hypertension, And then to implement a PA for our preferred phosphodiesterase 5 inhibitors to limit use for erectile dysfunction. And so adding PA to those drugs and then auto-approving prescriptions that look like they're being used for PAH. So if the member has a PAH diagnosis in their medical claims, if they have claims for other PAH drug classes, if they're female, or if the prescription is written by a pulmonologist. We don't have any PDL changes recommended based on the evidence, but are recommending that we go look at these costs in executive session. And with that, I think I've got PA criteria to walk through. So these are just the updates that we're recommending for to incorporate sotatercept into the criteria. So these are the injectable PAH criteria. And we're updating question number 4 to differentiate between the prostacyclin receptor agonist and this new drug with a new mechanism of action. And so if it's not a prostacyclin receptor agonist, you can get sotatercept if the member has functional class 2 through 4 symptoms. And we're still recommending it be prescribed in consultation with a pulmonologist or cardiologist. And then for the oral and inhaled therapy, just updating our criteria to clarify so I guess in number 9, clarify indications for the inhaled treprostinil, since we do have some evidence that there is harm in people with COPD. So we've updated that language in question number 9. And then in question 10 and 11, clarify that, or more explicitly clarify that treatment for erectile dysfunction, sexual dysfunction, or infertility is not covered under OHP. And I'm happy to take questions if people have them.
Nice job, Sarah. Any questions for Sarah? We do have some public comment. Nirmal Guman with Johnson & Johnson. Are you able to unmute your line?
Hey, can you hear me?
Yes, can hear you loud and clear. And the floor is yours for up to 3 minutes.
Thank you so much. Hi, everyone. My name is Nirmal Guman, and I'm a pharmacist and principal scientific account lead with Johnson & Johnson Innovative Medicine. Thank you for the opportunity to speak to you about Opsin-V. Opsin-V is a combination of macitentan, an endothelin receptor antagonist, and tadalafil, a phosphodiesterase 5 inhibitor, indicated for chronic treatment of pulmonary arterial hypertension in adult patients of WHO functional class 2 and 3. Individually, macitentan reduces the risk of clinical worsening events and hospitalization, and tadalafil improves exercise ability. Please refer to the full prescribing information for complete information. ADUE, a phase 3 study, evaluated the efficacy and safety of Opsin-V compared to macitentan 10 milligrams and tadalafil 40 milligram monotherapies in patients that have PAH, including treatment-naive patients and patients previously on ERA or PDE5 inhibitor monotherapy at baseline. The primary endpoint was change in PVR from baseline to week 16. In the 70 patients who were randomized to Opsin-V versus macitentan 10 milligram monotherapy, treatment with Opsin-V was associated with a 29% reduction in PVR compared to macitentan monotherapy. In the 86 patients who were randomized to Opsin-V versus tadalafil 40 milligram monotherapy, treatment with Opsin-V was associated with a 28% reduction in PVR compared to tadalafil monotherapy. In treatment-naive patients, treatment with Opsin-V was associated with a 30% and 34% reduction in PVR compared to macitentan and tadalafil monotherapies, respectively. In patients receiving prior ERA therapy, treatment with Opsin-V was associated with a 32% reduction in PVR compared to macitentan monotherapy, and in patients receiving prior PDE5 inhibitor therapy, treatment with Opsin-V was associated with a 19% reduction in PVR compared to tadalafil monotherapy. The most common adverse events observed with Opsin-V were edema or fluid retention, anemia, and headache or migraine. Qualitative one-on-one semi-structured web-assisted interviews were conducted across multiple countries with ADUA trial participants and site investigators about their experience with the single tablet combination therapy compared to individual monotherapies, focusing on adherence, convenience, and the impact of a reduction in pill count. All participants prefer the single tablet combination therapy during the open label extension to the 4 tablets they had to take in the double-blind phase. Patients stated it was convenient, aided adherence, and had a positive impact on their day-to-day lives. Additionally, patients acknowledged that it improved their psychological well-being and reduced the stress of managing multiple tablets. Clinicians cited that the high pill burden in PAH causes their patients emotional distress, whereas patients had higher treatment satisfaction with the single tablet combination therapy. Clinicians from the interview predict that the combination therapy will be well received in clinical practice and endorse prescribing it for treatment-naive patients. For these reasons, please consider adding OPSYNVI to the preferred drug list. Thank you for your time and consideration today.
Thank you, Nirmal. Any questions from the committee? All right. Next, we have Aaron Hu, pharmacist with Merck. Aaron, are you able to unmute your line?
I am Roger. Can you hear me?
Hear you loud and clear, and the floor is yours for up to 3.
Thank you kindly. Good afternoon. My name is Aaron Hoovey, a Health System Medical Affairs Director with Merck. I'd like to take a moment to address the recent approval of sotatercept, as Sarah had just reviewed. Sotatercept is also known as Winrevair, which is the first-in-class activin signaling inhibitor approved for the treatment of pulmonary hypertension. It's most important to note, and also Sarah pointed out, that the consensus guidelines in both the US and Europe have not been updated since 2022, which is well before the approval of sotatercept. With that said, this past summer, the World Symposium on Pulmonary Arterial Hypertension, or WSPAH, convened. And this is actually an event that occurs every 6 years, and it really brings together PH experts from around the globe to encourage meaningful scientific dialogue and collaboration. As a result of the discussions at the symposium, a new treatment algorithm for PH has been proposed and published. This updated algorithm incorporates recent therapeutic developments, including sotatercept, and recommends a transition towards risk-based stratification for initiating and modifying treatment. According to this guidance, sotatercept is considered as an add-on therapy for patients that remain in intermediate low or intermediate high risk stratifications, as assessed 3 to 4 months after the initial assessment and commencement of therapy. I'm open to any questions the committee may have. However, if there are none, I would like to yield the remainder of my time to the committee. Thank you for your time.
Appreciate that, Aaron. Committee, do you have any questions for Aaron or Merck's product? All right, thank you.
Thanks, Roger.
And last, you bet. Andy Kim with United Therapeutics. Are you able to unmute your line?
Yes. Can you guys hear me okay?
I speak again. It's kind of a little hard to hear.
Can you guys hear me okay?
You bet. Can hear you, and the floor is yours for up to 3 minutes.
Thanks, Roger. Good afternoon. My name is Andy Kim, and I'm a medical science liaison with United Therapeutics Corporation. In May 2022, the FDA approved Tyvaso DPI for the treatment of patients with pulmonary arterial hypertension, PAH, and pulmonary hypertension due to interstitial lung disease, PH-ILD, to improve exercise ability. Tyvaso DPI is a new formulation and inhalation device for Tyvaso and is the only dry powder inhaler approved by the FDA for use in both PAH and PH-ILD. Tyvaso DPI was evaluated in the BREEZE study, and the primary objective was to evaluate the safety and tolerability of Tyvaso DPI during a 3-week treatment phase in 51 PAH patients on a stable regimen of Tyvaso inhalation solution who were transitioned to Tyvaso DPI. Patients who transitioned from Tyvaso to Tyvaso DPI demonstrated safety and tolerance. 96% of patients completed the 3-week treatment phase, while 2 subjects discontinued due to treatment-related adverse events. Adverse events were consistent with studies of inhaled treprostinil in patients with PAH, and there were no study drug-related serious AEs. Significant improvements in secondary study objectives were also observed at week 3, including 6-minute walk distance of 11.5 meters compared to baseline, overall patient satisfaction with the Tyvaso DPI inhaler as measured using the preference questionnaire for inhaled treprostinil devices, PAH SYMPACT patient-reported outcome questionnaire were observed in physical impacts and cognitive and emotional impacts. The 49 patients who completed the treatment phase of BREEZE opted to continue in an optional extension phase. Improvements in 6-minute walk distance compared to baseline were sustained in the optional extension phase through the data cutoff time of up to 51 weeks. Given these findings, we ask that you please make Tyvaso and Tyvaso DPI preferred on the Oregon Medicaid PDL for PAH and PH-ILD patients that depend on your services for their medications. Thank you for your attention. I'm happy to answer any questions. I yield back my time.
Appreciate it, Andy. Any questions for Andy or United Therapeutics? Okay. Recommendations are back up on the screen in front of the committee. So again, the recommendations we are proposing, implement the PA criteria for sotatercept, support the use as add-on treatment for PAH, and no changes are recommended based upon the clinical information, but we would recommend implementing the PA criteria for the preferred PDE5 inhibitors so that we limit use for erectile dysfunction and auto-approve prescriptions when we have those criteria listed with the firm 4 bullets. Any discussion? Or additional questions for Sarah or recommendations for edits? And if not, then we would entertain a motion to approve.
Motion to approve as outlined.
Thank you, Doug.
Second.
Is there a second there somewhere?
Second, this is Eddie.
Thanks, Eddie. All right, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
Great, thank you. All right, moving on, we'll draw your attention to page 155 in the packet of materials. We have the COPD class update with another new drug evaluation. And Deanna, we're going to turn it over to your able hands.
All right, thanks, Roger. So we're going to be talking basically about miscellaneous pulmonary agents. You may recall that earlier this year in February, we looked at the inhalers for COPD and asthma. We're going to be looking at some of the oral agents. So if we could go to the next slide. Thanks, Sarah. The class update was to look at see if there was any new literature that was published for these, basically the leukotriene inhibitors, montelukast, zarfolukast, and Xolutin, and then also there's the PDE4 inhibitor, roflumilast. Since we last looked at this class in particular, in October of 2020, and there was no new high-quality evidence that was published to compare the safety and efficacy of these oral products in people with asthma or COPD. However, as Roger mentioned, there is a new nebulized product, ensifentrine, and dupilumab also received an expanded indication to its already long list of approved indications. So we'll be looking at the evidence for that. So if we can go on to the next slide. The Global Initiative for Asthma, or the GINA report, was updated earlier this year. And their recommendations for using the leukotriene receptor antagonists hasn't really changed for the treatment of asthma, specifically because they're not as effective as the inhaled corticosteroids, especially for exacerbations. So they're basically recommended as alternatives or add-on therapy to preferred inhalers. GINA did add some guidance about looking at the risks and benefits of montelukast, because we've had a black box warning that was added in 2020 to montelukast about the warning of potential behavior and mood-related changes when starting this medication. If we could go on to the next slide, please. I mentioned that Dupixent or dupilumab got a new indication for treatment of adults with COPD that are already on maintenance therapy and not adequately controlled. So the FDA based that approval on two pooled data from two randomized controlled trials that were conducted over 52 weeks, and their main primary endpoint was to look at the annualized rate of moderate or severe COPD exacerbations. And in both trials, the patients had to have a blood eosinophil count of at least 300 cells per microliter and elevated exacerbation risk, despite using the standard triple asthma inhaler therapy, COPD therapy, excuse me. So it was a placebo-controlled trial. Both trials were placebo-controlled, and dupilumab did reduce the annualized risk of exacerbations, 0.78 versus 1.1. So that was statistically significant. In terms of clinical significance, one could argue that it didn't even meet 1, but it was only over 52 weeks. And similar results were seen in the other randomized controlled trial. Next slide, please. So we'll move on to the new drug, ensifentrine. This is a unique agent because it's a dual phosphodiesterase PDE3 and PDE4 inhibitor. So by impacting PDE3, that increases airway smooth muscle tone, and then by impacting PDE4, that promotes inflammatory cell activation. So this is a nebulized treatment, and it's approved for maintenance treatment of COPD in adults. Next slide, please. So the clinical trial that the FDA used was a double-blind, placebo-controlled, parallel group randomized controlled trial in which the ensifentrine was compared to placebo, a fairly large trial. You can see the adults with moderate to severe COPD who are aged 40 to 80 years of age with a smoking history of at least 10 pack years were included. They had to be taking either a long-acting muscarinic antagonist or a long-acting beta agonist with or without inhaled corticosteroid therapy. Patients that were taking LABA or triple therapy were excluded. This trial was conducted between September 2020 and December 2022 before the guidelines were updated to recommend using LABA/LAMA or the triple therapy combination in patients with moderate to severe COPD. So it's a little bit behind, the inclusion criteria is a little bit behind the times in terms of what's considered guideline-directed therapy. The duration of therapy was for over 12 weeks, and the primary outcome was kind of unusual. It was a change in the forced expiratory volume over 1 second, and they looked at the area under the curve from 0 to 12 hours. Now, the FDA had recommended that the manufacturer look at morning trough forced expiratory volume as the primary outcome, because they felt like that would provide insights as to the impact of the medication's duration of activity through the end of the dosing interval. The manufacturer used the trough forced expiratory volume as a secondary endpoint. The primary endpoint was statistically significant when compared to a placebo. For the secondary endpoint of change in trough forced expiratory volume, because they used a hierarchical assessment looking at secondary outcomes, it was considered statistically significant, the change in ENHANCE 1, but not in ENHANCE 2. So if we could go on to the next slide, please. So I talked a little bit about the trial limitations in terms of the primary endpoint, and then also the fact that the patients that were on concurrent LAMA or triple therapy were excluded from enrollment. It had a very small proportion of people that identify as Black or Hispanic, where that information was recorded. It was very limited. We don't know what the impact on COPD exacerbations is with this drug because the COPD exacerbation endpoint was an exploratory endpoint. And then also, this is only approved in adults. We don't know how effective this drug is in pediatric patients. And we don't have head-to-head trials to see what the efficacy of this drug is with other COPD maintenance medications because the only evidence we have is from those 2 trials that were placebo-controlled. If we could go on to the next slide, please. In terms of clinical safety, you can see the biggest side effects were back pain, hypertension, urinary tract infections, and diarrhea compared to placebo. Next slide, please. So our recommendations are to, we don't think that the review of this current evidence warrants any changes in the PDL for the miscellaneous pulmonary agents. We do want to revise the PA criteria for dupilumab to include use in adults that have inadequately controlled COPD that are on triple inhaler therapy. And then we'd like to maintain ensifentrine as non-preferred with specific PA criteria to ensure that its patients are using guideline-directed therapy prior to adding ensifentrine to their therapeutic regimen. And then I did not add this as a recommendation, it's not in your packet, but we also revised the roflumilast PA criteria to specify that we're talking about oral tablets because a topical roflumilast agent was approved last year for inflammatory skin disease. And then we also added renewal criteria for the roflumilast. So the PA changes are in the packet. I just neglected to add the recommendation there. So this is the change that we had for the oral roflumilast was just to stipulate that it's for the oral drug. And then we added a statement there about what requires PA, that the topical agent is subject to separate PA clinical criteria. We can go to the next slide, please. So the change there is we're just added the renewal criteria. So we added question 2 about going to renewal criteria. And the next slide outlines what the renewal criteria are. And then basically, does the provider attest that the patient's condition is improved with the roflumilast treatment? So those are the changes for the roflumilast. The next changes, they start on page 177. So our dupilumab criteria are part of the targeted immune modulators for asthma and COPD. So what we did was we revised table 1 to add COPD as a new indication. And then we had also added the expanded indication for benralizumab. Previously, it's now approved for EPGA. Next slide, please. So table 2, we just added what conventional treatments we're looking for with COPD, and that's based on the GOLD guidelines about using triple inhaler therapy or LABA/LAMA for at least 3 months for severe COPD. Next slide, please. And then we updated table 4 to add what we're looking for disease severity for COPD. So because dupilumab everybody had elevated blood eosinophil counts, we included that, as well as looking at how many exacerbations they had that required either a hospitalization or an ED visit. Next slide, please. So the biggest change was that we modified the renewal criteria to add, is it a request to renew therapy for asthma or COPD, or are they currently, and question 4, are they using triple inhaler therapy? Those tables are included as part of the questions to help streamline the therapy. So the questions were already addressed for that. And then the next slide, it talks about how many COPD exacerbations they had, if they're looking for renewal for dupilumab for COPD. Then the next slide, we talk about the new PA criteria for ensifentrine. So basically, we just want to make sure that it's promoting use that's consistent with practice guidelines in people with COPD. Next slide, please. So just our standard, what diagnosis does the patient have? Is it request for continuation of therapy? So we have renewal criteria. We're asking, does the patient have COPD? And then we're asking, do they have a prescription for a long-acting bronchodilator or an inhaled corticosteroid? And then also, we're also asking if the prescriber is a specialist in respiratory medicine or if it's in consultation with a specialist. And that is all I have. So next slide, are there any questions from the committee about the recommendations I put forward for you?
Great job as always, Deanna. Questions for Deanna? And unbelievably, Deanna, we have a class you've presented with no public comment. So you usually bring people out of the wood. It is. So again, to the committee, any questions about what Deanna presented or about the recommendations in front of you? Okay, again, just to recap, no changes are being recommended based on the evidence. Update the roflumilast PA criteria. Update the PA criteria for dupilumab to include adults with inadequately controlled COPD on triple therapy. And to maintain ensifentrine non-preferred and implement that proposed PA criteria to ensure the patient are using directed therapy prior to adding it on. Do we have a motion to approve?
So moved.
Thank you, Eddie.
Do I have a second?
Second.
All right. All those in favor?
Aye.
Aye.
Opposed? Abstain? All right. Thank you.
Well, we are cruising right along. So we are going to take a 15-minute break. With that, powder your nose, and we'll see you back here in 15 minutes to finish up with the agenda and go into executive session. Thank you. Okay. Getting to the end of the break here. Hope everybody had a sufficient amount of time to do what they needed to do. With that, if you're following along on the pack of the materials, direct your attention to page 186, and we'll turn it over to Sarah Fletcher for the urea cycle disorders.
Thanks, Roger. If you go to the next page, we are talking about the urea cycle disorders, and this is a new class. This isn't an update, but this is the first time that we're looking at these agents. And so the purpose is to identify the drug class and identify some appropriate utilization management strategies. If you go to the next slide. As far as background, urea cycle disorders are the result of a deficiency of an enzyme or a co-transporter in the urea cycle pathway, and this results in nitrogen being unable to be cleared appropriately from the body, and patients can develop hyperammonemia, which can cause in little children things like poor feeding and vomiting, and it can progress along a spectrum all the way to cerebral edema, seizures, organ failure, and death. And the FDA does use ammonia levels as a surrogate for morbidity and mortality. They're associated with adverse neurologic outcomes, coma, and death, and they're accepted as the primary endpoint in different studies. And that table off in the right corner, those are the names of the different urea cycle disorders. Most of them are treated similarly, and then I'll just point out that NAGS is a little bit different, and it's one of the most rare. It's about 1 in 2 million, and it does have a different drug treatment that we're not looking at today. If you go to the next slide. The treatment for the urea cycle disorders, primary is actually nutrition, which involves low protein diets that are closely monitored. But on a drug spectrum, for the outpatient treatment, there's primarily 2 different agents. There's glycerol phenylbutyrate and sodium phenylbutyrate. Now, the glycerol product has 3 of the phenylbutyrate molecules, and those are released in the GI tract by pancreatic lipases, and then that is oxidized to phenylacetate. The sodium phenylbutyrate is a prodrug, and it is metabolized to phenylacetate, so they both get converted to the same thing. And then phenylacetate is a metabolically active compound that is conjugated to glutamine, which contains nitrogen. And then that forms a new molecule called phenylacetylglutamine, and that's excreted in the kidneys and provides a way for these patients to get nitrogen out of their body. And at the bottom, you'll see the note carboglu or carglumic acid is not part of this review. It's used to treat NAGs, but not the other indications. And these drugs are not used to treat NAGs, so they don't overlap. And then nutritional supplementation, things like non-protein infant formula are dictated by specific OAR 410-148-0260. And our nutrition policy is aligned with that. And it's been recently updated, and we're going to re-update it to align with that policy. So that's not part of our P&T review. It's just informational. So if you can go to the next page. So I said that there were 2 main products, but they're actually divided into 4 different marketed products. The glycerol phenylbutyrate, or Ravicti, is a liquid, and it can be administered directly into the mouth, or with special instructions, it can go down feeding tubes. And then the other 3 products are all different forms of sodium phenylbutyrate, and that product is generally considered to be pretty unpalatable. And so you'll see the first 2, the Feburane and the Olpruva, are both coated pellets used to make the product easier to tolerate being taken, especially when it's a little child. So the Feburane is a coated pellet or a granule, and it can be put in liquids or formula or sprinkled on the food, and it's dosed with a calibrated spoon that comes with the package. And all of the sodium products do have a pretty heavy sodium load. And so the max dose of 20 grams a day, which would be the max for an adult, does have 2.5 grams of sodium in it. And both of the pellets are not appropriate for G tubes or for feeding tubes. The Olpruva is approved for adults and peds over 20 kilos, but not for smaller children because it comes in pre-dosed dosing packets, and the smallest one is 2 grams. And it's similar to the other one, it's not appropriate for a G tube. And then at the bottom, you'll see Buphenyl, and it's generic. That's the old product, it's not coated, and it's generally not well tolerated by most patients. And the tablets are not recommended for those under 20 kilos, but the powders can be given down a tube or to children who are smaller. Now, there are some nuances in how the FDA, the indications and how they're approved, and that's in the packet on page 189. But generally, all of the sodium products are approved for 3 of them. The Ravicti does have an approval for all of them, but mechanistically, they all make phenylacetate, and so they work in the same way. So if you go to the next slide. As far as the evidence, in this class, I found no systematic reviews or guidelines that compared the products. There were some clinical context guidelines that weren't high quality, but they did not specifically recommend certain formulations over another. And then the next slide. There's 4 studies that I included. This is 2 of them. One of them is an open label switch study on the left, and then on the right, there is a double-blind study. But these were the transitions from a sodium phenylbutyrate to a glycerol phenylbutyrate product. They're both quite small. The one on the left has 15 patients versus 44 on the right. The left study was pediatrics, 29 days to 6 years old. And then on the right, we have adults, and the median age was 28 years. And they included all UCD subtypes except for NAGs. And the primary outcome on this switch study was the mean ammonia level over 24 hours, so the AUC over 24 hours. And then that was compared in a ratio of geometric means. On the left, it was 0.79, on the right, it was 0.91, and that fell within their non-inferiority range, which was 1.25. And so it was just a non-inferiority transition study. If you go to the next slide. This one is, again, this is transitions to glycerol phenylbutyrate. Some of the patients were naive because of their age, but there's 10 participants in the pharmacokinetic study with the Berry study and 16 on the right with the Longo. The difference in these 2 is the left is 2 months to 2 years of age in demographic, and the right was newborns to 2 months old. Pharmacokinetically, both groups were considered to, quote, successfully transitioned, and that was defined as an ammonia level of less than 100 and no clinical symptoms. And then before the transition, 11 patients in the 2 month to 2 year group had had a hyperammonemic crisis, that's HAC. They had 36 of those. And then after, when they were followed up, there were 7 patients who had 11. And about 80% of the patients were followed for at least 3 months. A little over half were followed for at least 6 months. And then for the newborns, Before, about 6 of 16 had 1 hyperammonemic crisis. 1 patient had 2, and again, they were enrolled when they were very young. Afterwards, 3 of the 16 had 1, and then 2 of the 16 had 2 in that follow-up period. And the follow-up was similar. About 80% or so had 3 months of follow-up, and more than half of them had 6 months of follow-up. So you go to the next slide. Obviously, these trial limitations are switching studies. Most are open label. There were very small study populations, and if they were analyzed for statistics, it was a non-inferiority analysis. And so we don't have any really long-term comparative outcomes between these products. As far as clinical safety, because essentially they're very similar products other than the salt formulations, they do have some similar adverse effects, things like the phenylacetate that they're both converted to. If it's too high, it possibly could cause some neurologic damage. But the difference is the sodium-based products should be used with caution in those who are sensitive to sodium, like heart failure, renal insufficiency, or edema. The glycerol paste product should be used with caution in those with pancreatic or intestinal insufficiency. When it was first approved, I did find some information that said to not use it in newborns to 2 years old because of the potential that they don't have full pancreatic function. But you do see on the last slide where there were 16 patients in that study, and they did seem to transition while still under 2 months old. Next slide. So as far as the recommendations, there's insufficient evidence to really compare and contrast these agents based off of clinical or safety data. I would like to create a preferred drug class and potentially make some products preferred or non-preferred, but implement an auto PA to allow continuation of any therapy of those that we do make non-preferred after the initial approval. So if someone gets one product and then in a year they'll have this disease forever, they don't have to go through the paperwork again. And I'd like to evaluate the costs in executive session. And then informationally, the nutritional supplement PA is going to be updated to align with the current effective OAR. Are there any questions?
Nice job, Sarah. Any questions for Sarah? And we do have public comment from 2 members. I have tried to make Dajjal Nate Hamoud from Medunnik co-host. So you're able to unmute your line. Jalal, are you able to unmute your line? I see your microphone's going on and off, but it's not unmuting.
Hello, can you hear me?
Now I can hear you.
Great. Thank you so much. And thank you, Sarah, for the presentation, for the great presentation. My name is Jalal Naid Hamoud, and I'm pharmacist by training and MSL here at Medunique. Today, we'll be discussing Fiberan as treatment option for urea cycle disorder. Sodium phenylbutyrate is a nitrogen scavenger drug established a decade ago as the gold standard adjunctive therapy to the standard of care of urea cycle disorder, a life-threatening condition, has changed the prognosis of this condition by saving the patient's life and improving drastically their outcomes. Sodium phenylbutyrate non-coated formulation had been used since 1987 and was approved for marketing as Bufenil in the United States in 1996. However, bad taste or taste aversion are amongst the most frequent adverse events reported with commercial non-coated formulation of sodium phenylbutyrate and may cause taste disturbance and vomiting at intake, which makes their chronic use very difficult and may reduce treatment compliance. Since commercial non-coated formulation of sodium phenylbutyrate granules have an offensive taste, an improved tasteless pellets formulation of sodium phenylbutyrate, Fiberan, was developed whereby coating of individual pellets results in formulation which has no immediate taste. In French compassionate program cohort, in comparison with the non-coated formulation used before entering the cohort, Fiberan showed high acceptability, no vomiting, and ease of administration without any reconstitution, and improved control of ammonia plasma levels with no hyperammonemia crisis up to 30 months. Medunique offer access option. Fibran, the first palatable FDA-approved sodium phenylbutyrate for urea cycle disorder patients to help improve their compliance, thus their outcomes. Therefore, we respectfully request to include Fibran as preferred in your product list agreement, and I'm happy to answer any question you might have. Thank you.
Thank you, Jalal. Any questions from the committee? Okay, again, thank you for your time. Next, we have Abby Hatta from Amgen. Are you able to unmute your line?
I can. Can you hear me?
Yes, hear you loud and clear, and the floor is yours for up to 3 minutes.
Thank you. So my name is Abby Hatta, as mentioned. Thank you today for the opportunity to present and share important information about life-threatening rare diseases, urea cycle disorders, which Sarah so thoroughly summarized. And I'm going to be talking today about Ravicti or glycerol phenylbutyrate, which Amgen provides. So as Sarah mentioned and talked through, UCDs are devastating inherited diseases that interrupt the removal of excess nitrogen from the body and exhibit a broad spectrum of very serious clinical manifestations ranging from impaired cognition to permanent brain damage, coma, and death. Chronic compliance and adherence are critical components of better UCD patient outcomes. Ravicti has demonstrated ammonia control over a chronic period of years, as you heard about, in adults, pediatric patients, toddlers, infants, and even newborns. In addition, data on Ravicti demonstrate a significant reduction in hyperammonemic crises, significant decreases in clinical manifestations when compared to sodium phenylbutyrate, and significantly improved brain executive function. Data concerning these significant reductions of UCD-related manifestations does not exist for other nitrogen scavengers. The robust Ravicti clinical trial programs were championed by the patient community. Ravicti is nearly odorless and nearly tasteless with no time limitation placed on ingestion of the medication, whereas the taste mask versions of sodium phenylbutyrate have a time frame during which the taste is actually masked. In addition, as you heard, Ravicti can be administered via a G-tube while the taste mask versions cannot. Due to the grave risks involved with switching stable UCD patients to a new therapy, we ask that the board strongly consider, as which was mentioned in the policy, to allow existing stable Ravicti patients to maintain access to their current therapy without having to try a different formulation. Also, we request that patients have easy access to new therapy when they are newly diagnosed. I appreciate your time and consideration of the significant impact that interrupting therapy and limiting access will have on these patients. Thank you for your time.
Thank you, Abby. Appreciate your testimony. Does the committee have any questions for Abby? All right, thank you. The recommendations are back up on the screen for the committee. So for this class, we are recommending to add the class. So it's going to be a new class on the preferred drug list. Implement the auto authorization. So we're going to allow continuation of therapy as we start to implement preferred and non-preferred agents. And we're also going to evaluate costs in executive session. And the third bullet is just informational that the nutritional supplement PA guide is going to be updated to align with the OAR on your screen. So again, any questions for Sarah? And if not, we'll entertain a motion to approve.
Motion to approve.
Thank you, Russ. Do we have a second? We'll get the committee off mute.
Second.
Thank you, Samara.
All right, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
Excellent. Next, turn your attention to page 205 if you're following along in the packet of materials. We have the bone metabolism drug class update, and we'll turn it back over to Deanna.
Thank you, Roger. If we could go to the next slide, please. So the reason we're doing this update is to see if there's any new comparative evidence for the bone metabolism agents, which includes the bisphosphonates, alberoparatide, denosumab, romosozumab, and teriparatide for management of osteoporosis in women and men. And we want to make sure that our PA policies are consistent with current guidelines. The last time we looked at this class was July 2019, and so there is quite a bit of evidence that's been published since then, 5 systematic reviews and 7 clinical guidelines. Next slide, please. I just wanted to highlight what drugs we're talking about. So this is in your packet on page 210, but it's just a summary of the different classes, the bisphosphonates, some of the estrogen-related therapies, the parathyroid hormone analogs, and the rank signal inhibitor denosumab, the sclerostin inhibitor romosozumab. The preferred drugs on the PDL are the oral formulations of alendronate, ibandronate, and risedronate. All the rest of the drugs are non-preferred, basically raloxifene and any of the injectable agents. In the third quarter of this year, most of our utilization for these drugs was due to the preferred oral alendronate, about 99%, and we had 1% of claims for oral ibandronate. Next slide, please. So just to kind of highlight the systematic reviews, I put these two together because they were both looking at comparative efficacy of managing osteoporosis. The first one in 2022 looked at zoledronic acid versus alendronate, and it showed that there was no difference between the two agents in increasing the bone mineral density of the spine or the total hip after 1 to 2 years. The adverse event rates were pretty similar, but as expected, we saw less GI effects with the injectable zoledronic acid and more with the oral alendronate. And then the other systematic review looked at teriparatide versus bisphosphonates. There was 3 bisphosphonates that they looked at, risedronate, alendronate, and zoledronic acid. Those were the comparators. And the systematic review showed that the teriparatide group had a lower total occurrence of vertebral fractures and non-vertebral fractures compared with the bisphosphonates. And then also teriparatide was better at increasing the bone mineral density in the femoral neck at the final follow-up. And there was no difference in the rates of adverse events between the 2 classes of drugs. Next slide, please. Then we had some more reviews, romosozumab, which is the latest drug to enter this class, versus teriparatide for the treatment of postmental osteoporosis. And in that comparative analysis, romosozumab increased the bone mineral density more than teriparatide, and there was a lower incidence of injection site reactions. The next systematic review looked at glucocorticoid-induced osteoporosis, and it showed that teriparatide and denosumab were superior to the bisphosphonates at increasing bone mineral density in the hip and the lumbar spine. And then there was no difference in adverse events between the different drugs that they looked at. And then finally, there was a systematic review that looked at the safety of denosumab versus bisphosphonates. And less people withdrew that were on denosumab due to adverse effects. But being that denosumab is a monoclonal antibody, there were more infections and upper respiratory infections and infections overall, but there was less vertebral fractures and less abdominal pain with denosumab, which is to be expected given the route of administration and the mechanism of action of these drugs. Next slide, please. So the CADTH and NICE guidelines, they tend to issue guidelines that are drug specific. So in 2021, CADTH issued some guidelines about romosozumab, and basically they recommend that in people that are at high risk for fracture, and they define what high risk is as a 10-year fracture risk greater than 20% using the FRAX tool, that they should get romosozumab. They recommend that the patients be treatment naive, except for maybe calcium or vitamin D. The maximum duration with romosozumab is 12 months, and they also recommend that it not be prescribed concurrently with other meds. Then NICE came out with guidance in 2022 for romosozumab, which is very similar to CADTH. They just recommend it as an option for treating severe osteoporosis in people that are at high risk of fracture, or if they've had a major fracture within the past 24 months. And then in 2024, NICE updated their guidance for abaloparatide to say that it was reasonable to use in women, trans men. That's the first guideline I saw that recommended treatment in transgender individuals and non-binary people that are at very high risk of fracture. Next slide, please. In 2020, the Endocrine Society updated their osteoporosis guidelines, mostly to add romosozumab to the guidance. And very similar to what we saw with CADTH, it's recommended in their specific here, saying that it's for women with osteoporosis at a very high risk of fracture, or if they have very severe osteoporosis with a very low T-score, or if they've had fractures. And again, it's only recommended for 1 year. That's the maximum duration of treatment. They do go on to say in their guideline that women at high risk for cardiovascular events or stroke should not be considered because we need more studies on the safety of romosozumab in patients that have CV risk. And then they do recommend after a year of treatment with romosozumab to make sure that some other osteoporosis therapy is continued to maintain whatever gains were made in bone mineral density and to continue reducing the risk of fracture. Next slide, please. So it was easier to put some of these guidelines in a table. This is not the whole table that's on page 218. I just basically put the guidance for what medications should be used. In the packet, it talks about which patients should receive therapy and what the monitoring should be. But you can see here that the recommendations are very strong. And they're based on high quality evidence about when you should use the bisphosphonates versus the injectable agents. And the duration of treatment in 2020 was still recommended to limit abaloparatide and teriparatide to 2 years. So that's in their guidelines. And the same with romosozumab, only for a year. And then making sure that people go on anti-resorptive therapy after they finish those agents. The next slide is the Osteoporosis Canada 2023 guidance. Again, I just put the pharmacologic recommendations. They qualified their evidence based on what they found in females versus males, which was a little bit different than the Endocrine Society, the Joint Endocrine Society guidance. But again, they do recommend bisphosphonates first line, and then for people that are at high risk for fracture to advance to teriparatide or romosozumab. And then they do have some guidance about raloxifene only to use in people that are not at high risk of thromboembolism. Next slide, please. Then the final set of guidance, this is kind of unusual. The American College of Rheumatology came out with some guidance for using osteoporosis treatments in glucocorticoid-induced osteoporosis. The evidence is not as strong in this particular condition. Most of our evidence for the bone metabolism agents is in osteoporosis. So again, they do recommend starting with bisphosphonates And then also you can use the injectable agents if they're at very high risk for fracture. The evidence in women, in children there at the bottom is not very robust, mostly because children are not at high risk for fracture if they're getting glucocorticoids. So the evidence in pediatrics is low quality, and it's conditional recommendations for using these treatments in pediatrics. Next slide, please. We did have some expanded indications. So abaloparatide has an expanded indication to use in men now, men and women. And then we have a Prolia biosimilar that came out earlier this year, and it has pretty much all the same indications that denosumab has. So not only in osteoporosis, but also to use in prostate cancer and people that are getting therapy for breast cancer as well. Next slide, please. The FDA updated the safety guidance for teriparatide and abaloparatide. So initially, when these drugs first came out, there was a black box warning about the risk of osteosarcoma, which was seen in animals. In November 2020, the FDA removed the black box warning for teriparatide, and in 2021, they removed it for abaloparatide. The warnings are still part of the warnings and precautions section, and they say that these drugs should be avoided in patients that are at increased risk of osteosarcoma. And then in January of this year, a new black box warning was added to denosumab regarding the risk of severe hypocalcemia in patients with advanced kidney disease, including people that are on dialysis, that they're at greater risk of hypocalcemia. So the changes in the guidance in terms of the recommendations for high risk of fracture, the changes in the safety guidance, and then the expanded indications all impacted our PA criteria. So we'll go through what those changes are on the next slide. So we modified the first page to say that physician-administered claims for romosozumab will be subject to PA criteria. Next slide, please. And then we modified this, added this table 1 to define what patients are at very high risk for fracture. And it's basically everything that was in the guidelines that I just went through. So osteoporosis in postmenopausal women and men at very high risk of fracture with any of those risk factors. So either multiple fractures, low T-scores, fractures while they're on osteoporosis therapy, or if they're on long-term glucocorticoids, or if they are at high risk for falls. So this table is included in one of the questions for the Gainwell folks to refer to. Next slide, please. So we added number 2 to clarify that if the bone metabolism agent is being used for treatment of cancer-related issues, that we would approve for 12 months. And then we revised question 3, where we're adding renewal criteria because initially abaloparatide and teriparatide were only approved for 2 years. There's some new evidence that they can be continued beyond that if people are at high risk for fracture. So we wanted to include that in the PA criteria. And then we added the referral to table 1 in question 4. We want them to step through oral bisphosphonate therapy, or if they're at very high risk for fracture, then they can go right to the injectable agents if they need to. And then we added question 5 about calcitonin or zoledronic acid. Next slide, please. And then question 9, we added the renal function assessment for denosumab. given the black box warning. So we wanted to make sure that if they do have severely impaired renal function, that there's some sort of calcium monitoring plan in place because of the black box warning. And then the raloxifene, we just clarified that it's for women that are postmenopausal with osteoporosis. And then question 12 goes on to assess what's their cardiovascular risk for thromboembolism if they do need raloxifene. Next slide, please. And then we added abaloparatide to question 13. And then, like I said, we asked about, are they at very high risk for fracture? Again, referring to table 1. In question 15, we clarified what we meant by metabolic bone disease because osteoporosis is considered metabolic bone disease. So that was a request from Gainwell, which was very astute. So we just clarified that we were talking about Paget's disease in those risk factors or reasons that we would deny treatment therapy. Next slide, please. And then finally, this is the renewal criteria. So if the request is to continue romosozumab beyond 1 year, we would deny it because the labeling specifically says 1 year. But for abaloparatide or teriparatide, if they want to continue it beyond 2 years of therapy, we would like to have the provider attest that they are at high risk for continuing to have a fracture before we would approve it beyond 2 years of treatment. And with that, I'll just summarize the recommendations on the next slide. So no changes to the PDL are recommended. We did want to revise the PA criteria to align with the recently published guidelines and safety updates. And we will look at drug costs in exec session. And I think we do have public comment, right?
That's correct. But first, great job. Any questions for Deanna? Okay, hearing none. We have Shannon DiBartolo from Amgen. Are you able to unmute your line?
Yes, I'm here. Can you hear me?
Hear you loud and clear, and the floor is yours for up to 3 minutes.
All right, thank you. Good afternoon. My name is Shannon DiBartolo, and I am a medical value and access liaison with Amgen Scientific Affairs. I'm here today to provide testimony for both Prolia and Avinity in support of Amgen's request that the committee continue to cover both products to label. Prolia is an anti-resorptive rank ligand inhibitor approved for the treatment of the following who are at high risk for fracture: postmenopausal women with osteoporosis, men with osteoporosis, treatment of glucocorticoid-induced osteoporosis, and to increase bone mass in men and women receiving hormone blocking therapy as part of a cancer treatment regimen. Avinity is an anabolic sclerostin inhibitor approved for the treatment of osteoporosis in postmenopausal women who are at high risk for fracture, which is being defined as having a history of osteoporotic fracture or having multiple risk factors for fracture. Additionally, it is approved for patients who have failed or are intolerant to other available osteoporosis therapies. In July 2024, the American Society for Bone Mineral Research and the Bone Health and Osteoporosis Foundation released a joint position statement addressing advances in clinical evidence as well as practice. An international task force of clinical scientists and expert physicians developed recommendations to update prior reports, provide a practical framework for managing osteoporosis, and to supplement published guidelines. Key statement points included prioritizing osteoanabolic therapies as initial treatment for some patients, avoiding step therapy, and ensuring appropriate treatment sequencing to achieve a target T-score within 3 years to reduce fracture risk. In conclusion, both Prolia and Avinity have been proven highly effective in increasing bone mineral density and reducing osteoporotic fracture risk. I respectfully request continued coverage of these medications to label and the adoption of the P&T committee's proposed edits to incorporate risk factors for patients at high risk for fracture. This will ensure enhanced treatment options and improve care for patients covered by your plan.
Great, thank you, Shannon. Any questions from the committee for Shannon? All right, hearing none, we have the recommendations that Deanna have outlined for you. No changes to the PDL recommended based on the evidence. Revise the criteria to align with the recently published guidelines and safety updates. And we are planning to review the costs of some of the agents in exec session. So questions or motion to approve?
I'd like to move to approve.
Thank you, Samara.
Second.
Thank you, Eddie.
All right, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? Thank you.
All right, fantastic. Last class of the day, platelet inhibitor class update. It again, if you're following along in the packet of materials, starts on page 236. And Kathy, the floor is yours.
Great, thanks, Roger. So the purpose of this update is just to look at new evidence since the last review, which was done back in 2021, and make sure that our PDL aligns with the current evidence. The new evidence that was identified was 9 systematic reviews and meta-analyses, 9 guidelines, 3 guidelines for clinical context, and then 3 updated safety alerts. Our current policy is basically all the drugs in this class, but 2 are preferred. Ticagrelor and then an aspirin or omeprazole combination product are both non-preferred at this time. And they do have to go through a PA to ensure that they are used for approved diagnosis and that patients don't have contraindications to therapy. This class is not a big spend for the OHA. There's only about 1,000 claims for antiplatelets in Q2 of 2024, in which 90% of those were for aspirin and then 10% were for clopidogrel. Just a quick background reminder, the FDA approved indications for antiplatelets span quite a different variety of indications, starting with aspirin and extended release dipyridamole is approved for decreasing stroke risk. Clopidogrel is approved for acute coronary syndromes, MI, stroke, PAD, or peripheral arterial disease. Silostol is approved for intermittent claudication or PAD. And then dipyridamole is primarily used for valve replacement. Prasugrel is one of those P2Y12 inhibitors, and it's approved for ACS in patients undergoing PCI. It's one of the preferred therapies for that. And then ticagrelor, which is approved for ACS, CAD, stroke, and stent thrombosis. And then, of course, aspirin alone isn't on there, but it's used for a variety of things such as secondary cardiovascular and stroke prevention, as well as PAD, preeclampsia, and then many more indications. So looking briefly over the systematic reviews, there's quite a few, mostly from Cochrane. We'll start first with the antiplatelet agents used for chronic kidney disease. And they did find that use in this population did reduce the risk of MI, both fatal and non-fatal, but did increase the risk of major bleeding. This was based on moderate strength of evidence. A second review looked at antiplatelets for the treatment of adults with COVID-19. They actually found low quality evidence that thrombotic events were decreased in those with COVID-19 treated with antiplatelets. And these results weren't actually statistically significant, and it was a short-term follow-up just up to 28 days. Next, Cochrane looked at oral antiplatelet therapy for acute ischemic stroke, and they did find that aspirin reduced the death and dependency and risk of recurrent ischemic stroke in patients that had experienced an ischemic stroke. However, when they looked at aspirin use or antithrombotics in general in those with intercerebral hemorrhage, they found that it did not improve outcomes. Looking at the next slide, antiplatelet agents used for hypertension. This was actually, they only found low quality evidence that aspirin reduced non-fatal cardiovascular events more than placebo and all cardiovascular cardiovascular events. However, a majority of these patients, almost 70% in the trials, were primary prevention patients, and they did find no cardiovascular mortality benefits. And not surprisingly, they did see an increased risk of bleeding. Cochrane looked at xylitol for intermittent claudication and found that it was more effective than placebo, increasing that maximum walk distance on the treadmill. But it again was associated with increased adverse reactions. This one was headaches, which is common with systolizol. Excuse me, can't talk. USPSTF looked at aspirin use to prevent cardiovascular disease and colorectal cancer. They did find that low-dose aspirin used for primary cardiovascular prevention did reduce the odds of experiencing a cardiovascular event, but they did not find a reduction in mortality or all-cause mortality. And they also looked for evidence of aspirin reducing colorectal cancer risk, because we have seen this in some studies. However, results were inconclusive as most of the evidence was from long-term observational data. There was, of course, an increased risk of major bleeding with aspirin use. Another USPTF review looked at aspirin use in preeclampsia, and they did find that it did reduce the risk of preeclampsia. These were high-risk individuals. And it also demonstrated a 21% reduction in the risk of perinatal mortality compared to placebo. And it was not associated with any kind of increased risk of postpartum hemorrhage. Next, review looked at a dual antiplatelet therapy after PCI in patients that also had an indication for long-term anticoagulation. And so they were looking at optimal duration of therapy. So they compared abbreviated DAP therapy, so lasting 4 to 6 weeks, to the standard, more prolonged treatment duration of 3 months or greater in patients undergoing PCI. And they did find that the shorter abbreviated treatment duration did demonstrate a reduced incidence of major bleeding as well as clinically relevant non-major bleeding without increasing any risk of ischemic events. And then just of note, most of the patients were on clopidogrel, so we know that this is a little bit less of a potent P2Y12 inhibitor than the other therapies. And then the other therapy used, the anticoagulant, most patients had AFib, and they were on 81% of them were on apixaban. Next, we're going to move on to guidelines. So we're going to look at NICE, and they came out with a guideline for cardiovascular risk assessment and reduction, and recommended that aspirin not routinely be used for primary prevention of cardiovascular disease based on their evidence up to 2023. USPSTF also published a recommendation for cardiovascular disease prevention, and this again was based off the systematic review that we just spoke of. And they recommended so that adults ages 40 to 59 who are at 10% or greater risk of cardiovascular disease should consider low-dose aspirin for primary cardiovascular prevention. But these recommendations really should be individualized per patient, and discussions around that, because the net benefit is small, and as we know, there is an increased risk of bleeding. And then they recommended that for those 60 and older, that they recommended against aspirin for primary cardiovascular prevention. And then a guideline recommendation done by the American Heart Association in collaboration with other organizations published a guideline for the management of patients with chronic coronary disease. And they recommend the use of aspirin for secondary prevention of patients with CCD that aren't on an oral anticoagulant for another indication. And they too recommend the dual antiplatelet therapy in patients with CCD that undergo PCI for at least 12 months. And they specifically do recommend a more potent P2Y12 inhibitors such as prasugrel or ticagrelor, because these are better platelet inhibitors and have less intersubject variability compared to clopidogrel. And so unless the person has other bleeding risk factors, they recommend those two therapies. The HA and ASA published guidelines for the prevention of stroke in patients with stroke and transient ischemic attack, and they do recommend aspirin 81 to 325 milligrams a day for certain patients for secondary prevention of stroke if, again, they have a history of stroke or TIA. They also provided a fair amount of other recommendations. So those are on table 9 in the on page 252 in the packet if you're interested. But that was one of their main recommendations based on high quality evidence. NICE came out with guidance for the management of heart valve disease, and they do recommend, just as far as antiplatelets are concerned, they recommend that aspirin or clopidogrel, if aspirin is not tolerated, for those patients that have had a transcatheter aortic valve implantation. ACC, in collaboration with other organizations, came out with coronary artery revascularization guidelines. They too recommend ticagrelor, prasugrel, in preference to clopidogrel in patients with acute coronary syndrome undergoing PCI to, again, reduce those ischemic events such as stent thrombosis. Another guideline came out of one of those systematic reviews that we talked about. The USPSTF recommends that those pregnant persons at high risk of preeclampsia should use aspirin 81 milligrams a day as a preventative therapy after 12 weeks gestation. The Canadian Cardiovascular Society came out with guidelines for PAD, and they do recommend the use of an anticoagulant such as rivaroxaban and aspirin, so dual therapy for people with symptomatic lower extremity PAD at high risk. Now, I would mention that those with symptomatic lower extremity PAD at lower risk, combination therapy is recommended, or just monotherapy with aspirin. In 2024, ACC, along with a variety of organizations, came out with a guideline for management of lower extremity PAD, and they too recommend antiplatelets as a mainstay of therapy, highlighting the use of aspirin or clopidogrel as the therapies that have the most evidence for use in this population. A few new safety updates for you. The first one's for clopidogrel. This is a drug interaction with rifampin. Again, they both use the same enzyme system for metabolism, so it's not surprising that when they're used concomitantly, there is an increased risk of bleeding, and so it is not recommended. For ticagrelor, we have two. One is that it can possibly worsen central sleep apnea, so these patients should be monitored a little more closely. And then secondly, for patients on dual therapy with aspirin and they're with CID that are undergoing PCI, it is recommended that the aspirin be discontinued due to increased risk of bleeding before that procedure. So the recommendations for this class is just we recommend changing ticagrelor to a preferred agent on the PDL due to evidence that it does have superior efficacy compared to other platelets for some indications, and then to retire the platelet inhibitor PA and to default just to the general non-preferred product PA criteria. Because as I mentioned, especially if ticagrelor is preferred, then we'll only have one non-preferred product, which is an aspirin omeprazole combination. So I'm happy to take any questions or comments.
Yeah, no public comment. No one signed up for that, but good job, Kathy. Any questions from the committee? Hearing none, then the recommendations are in front of you, and we'd entertain a motion to approve.
This is Jeannie. I'll make a motion.
Thank you, Jeannie.
Doug Carr, second.
Thank you, Doug.
All right. All those in favor?
Aye.
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 Anyone opposed? Abstain? All right. Thank you.
Well, that concludes the information we wanted to present to you. We need to go into executive session to discuss some confidential information. I have to read a blurb to you. No decisions will be made in executive session, and we will reconvene as soon as we're finished to make final recommendations. So the P&T committee will now meet in executive session for the purpose of consideration of information or records are exempt from disclosure by law. Executive sessions held pursuant to ORS 1926602F and ORS 4143561 and 2, which allow the P&T committee to meet in executive session to discuss confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that's necessary for the committee to make final recommendations or to comply with the requirements of ORS 4143553. Representatives of the news media and designated staff should be allowed to attend the executive session, and all other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session, except to state the general subject of the session is previously announced. No decision may be made in executive session. At the end of the session, we will return to open session. And with that, for the committee, we're going to move you over into the breakout room. Okay, recording's back on. We are returning from executive session. Give us just a second. I'll get acclimated and get off of our phones off of mute so I can do a head count. Great, I've got 8 committee members, well over our quorum. Okay, so after review of pricing in executive session, we'll take these one by one. We looked at the ADHD drugs that were part of the consent agenda lit scan. The recommendation is to make dextroamphetamine ER capsules, amphetamine tablets, and methylphenidate tablets extended release preferred agents. Any discussion or entertain a motion?
Doug Carr, so moved.
Thank you, Doug.
Second.
Thank you, Samara.
All right, all those in favor?
Aye.
Anyone opposed? Abstain? All right, thank you.
And for the pulmonary hypertension drugs, the recommendation after review in executive session is to make tadalafil tablets preferred. Discussion or motion?
Motion to approve.
Thank you, Eddie.
Second.
Thanks, Kat.
All right, all those in favor?
Aye.
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 Opposed? Abstain? Thank you.
For the urea cycle disorders class, the recommendation is to make Febuarane preferred, and we'll proceed with accepting a supplemental rebate offer, to make Bufenil and the generics preferred, and to make Ravicti and Plurva non-preferred. Discussion or motion?
So moved.
Thank you, Doug.
This is Jeannie. I'll second.
Thank you, Jeannie.
All right, all those in favor?
Aye.
Aye.
Opposed? Abstain? All right.
And finally, for the bone metabolism drugs, the recommendation after review in executive session is to make no changes to the PDL. So we'll entertain a motion.
So moved.
Thank you, Jeannie.
Second.
Thanks, Eddie.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you all.
Fantastic. Well, that concludes the December P&T meeting. Thank you all again for your continued volunteering for this important work. The next P&T meeting is slated for February 5th. I think on the 16th, about 2 weeks, we'll be posting draft materials. So invite you and anybody from the audience to review those, because we can accept public comment and feedback on those for consideration by the authors before final posting. So with that, thank you all. Happy holidays. I wish you all safe and enjoyable time, and hopefully some time off. So appreciate you.
Yep.
Thank you
thanks,
so
Roger.
much.
Thanks, everybody.
Thank you.
Thanks.
Thank you.